Good morning, everybody, and welcome to this press conference by the European Centre for Disease Prevention and Control. Please keep in mind that this briefing is being recorded and it will be made available on ECDC's YouTube channel after it has finalized. Today, we are releasing the latest data on healthcare-associated infections and antimicrobial use in European hospitals. I have with me Dr. Andrea Ammon, ECDC Director, and Dr. Dominique Monnet, who is the head of section for antimicrobial resistance and healthcare-associated infections. Dr. Ammon, the floor is yours.
Thank you, Andrea. Good morning from my side. Today, we want to address a pressing issue that affects the healthcare systems across the European Union and European Economic Area, and that is healthcare-associated infections. ECDC estimates that each 4.3 million patients in the EU-EEA acquire at least one infection during their stay in a hospital. This information comes from the third-point prevalence study of healthcare-associated infections and antimicrobial use in acute care hospitals that ECDC coordinated during 2022 and 2023. Simply put, these infections are infections that people get in hospitals while they are receiving care for another condition. Healthcare-associated infections make patients sicker and can prolong their stay in the hospital. In severe cases, these infections can also be life-threatening. 4.3 million hospital-acquired infections each year not only compromise patient safety, but also pose a formidable challenge to healthcare systems. On any given day, about 7%, so that's 1 in 14 patients in hospitals in the EU-EEA, have at least one healthcare-associated infection. This is an increase from about 6% observed in the previous survey that was conducted in 2016 to 17. Healthcare-associated COVID-19 was a significant contributor to the increased prevalence of healthcare-associated infections overall in 2022 and 23. Notably, SARS-CoV-2, the virus responsible for COVID-19, ranked as the fourth most common microorganism in healthcare-associated infections. Respiratory tract infections, including pneumonia and healthcare-associated COVID-19, represented nearly 1/3 of all reported healthcare-associated infections. They are followed by urinary tract infections, surgical site infections, bloodstream infections, and gastrointestinal infections. An increase was also observed for antimicrobial use. On the day of the survey, 36% of patients received at least one antimicrobial agent compared to 33% in the previous survey in 2016 and 17. Of particular concern is that 1 in 3 microorganisms detected in healthcare-associated infections were bacteria resistant to important antibiotics, thus limiting the treating options for patients. In light of these challenges, ECDC emphasizes the urgent need for coordinated action to mitigate the threat to patient safety posed by healthcare-associated infections. These actions include enhancing infection prevention and control in hospitals, ensuring adequate numbers of specialized infection control staff, improving their training and align qualifications across member states. At least 20% of healthcare-associated infections are deemed preventable by sustained and multifaceted infection prevention and control programs. Simple measures such as hand hygiene and ensuring that alcohol-based hand rub dispensers are available at bedside may considerably decrease the number of healthcare-associated infections. More complex interventions like an adequate number of single rooms to isolate patients with multi-drug resistant organisms and of specialized infection prevention and control personnel also play a crucial role in preventing healthcare-associated infections. However, there is currently significant variation in implementation of infection prevention and control programs across European hospitals. This indicates the need for standardized practices and enhanced efforts to improve compliance with infection prevention and control measures, starting with hand hygiene. Public health authorities are also encouraged to improve surveillance practices by conducting regular national point prevalence surveys of healthcare-associated infections. And finally, countries are encouraged to develop or improve antimicrobial stewardship programs aimed at ensuring that antimicrobials are used prudently to minimize the development of antimicrobial resistance. In conclusion, each year we have 4.3 million reasons to act, and we must act now by prioritizing infection prevention and control, optimizing antimicrobial prescribing practices, and strengthening surveillance efforts. We can really effectively mitigate the spread of healthcare-associated infections and safeguard patient safety. So we here at ECDC remain committed to continue supporting the UEA countries to improve their evidence-based response to healthcare-associated infections. And now I thank you for your attention, and I will give the floor to Dominique Monnet for additional data.
Thank you. Good morning. As Dr. Ammon just said, 4.3 million patients in hospitals in EA countries are estimated to acquire at least one healthcare-associated infections during their stay in the hospital. And some actually have more than one healthcare-associated infection. And the total of healthcare-associated infections actually has been estimated at 4.8 million. I would like to expand on three areas. Firstly, about the infections. 1/3 of these healthcare-associated infections were, in 2022-2023, tract infections, including pneumonia, and 7% were healthcare-associated COVID-19. To note, influenza, another common respiratory virus, was not commonly detected in our point prevalence survey, and this is because the survey was conducted in the spring and the autumn of 2022-2023, therefore out of the epidemic season for influenza. But we found healthcare-associated COVID-19, and the data highlight the importance of ensuring the implementation of measures to prevent COVID-19 and other respiratory viral infections in healthcare settings. These include early testing for the timely diagnosis of all respiratory viral infections, followed by the application of transmission-based precautions. And during periods of high prevalence of respiratory viral infections in the community, countries may consider either universal masking throughout the healthcare setting or continuous targeted masking of healthcare personnel. Besides the respiratory infections, urinary tract infections accounted for nearly 20% of all the healthcare-associated infections. Surgical site infections for over 15%, bloodstream infections for nearly 12%, and gastrointestinal infections for almost 10%. Notably, Clostridioides difficile infection accounted for nearly 2/3 of the reported healthcare-associated gastrointestinal infections and nearly 6% of all healthcare-associated infections. The prevalence of patients with at least one healthcare-associated infection on the day of the survey varied from 7.2% in tertiary care hospitals, that is the hospitals with specialized equipment and expertise for treating complex diseases, to 4.5 in primary care hospitals, the less specialized hospitals. And there were also variations in the prevalence of healthcare-associated infections according to the specialty. For these hospitalized patients with the highest prevalence in patients in intensive care units, 19.2%, compared to 5.2% for all other patient specialties combined. Now I would like to focus on antimicrobial resistance. 1 in 3 microorganisms detected associated infections were bacteria resistant to important antibiotics. And this actually limited the options for treating the patients with healthcare-associated infections. In European hospitals, the situation with Klebsiella pneumoniae, healthcare-associated infections resistant to carbapenems, and carbapenems are last-line group of antibiotics, continued to deteriorate in 2022-2023, with about 1 in 4 Klebsiella pneumoniae healthcare-associated infections being carbapenem resistant. Although there were large variations between European countries, this is a worrying trend because these infections can be common in hospitals and because there are few effective treatments available to treat patients with carbapenem-resistant infections. These data on carbapenem resistant from the point prevalence survey confirm what ECDC reported last November from the European Antimicrobial Resistance Surveillance Network, EARSnet, and ECDC will keep monitoring and regularly reporting on trends for this pathogen. Encouragingly, there have been notable improvements for healthcare-associated methicillin-resistant Staphylococcus aureus, or MRSA infections in several countries, resulting in an overall decrease across Europe. MRSA is an example of how the situation can shift to the better, but also a reminder that urgent action needs to take place for other multidrug-resistant bacteria such as carbapenem-resistant Klebsiella pneumoniae. Finally, I would like to emphasize, besides monitoring of antimicrobial resistance, antimicrobial use, and some of the most important action to prevent and control healthcare-associated infection. Strengthening infection prevention control measures, starting with hand hygiene and the use of alcohol-based hand rub for hand disinfection. This can be done by making sure that alcohol-based hand rub dispensers are available at the bedside. Number 2, ensuring an adequate number of specialized infection control personnel with up to 1 infection prevention control nurse per 100 hospital beds. Third, ensuring that in each hospital, there is a sufficient number of single rooms, so there is capacity to isolate patients with multidrug-resistant bacteria, such as carbapenem-resistant Klebsiella pneumoniae. This point definitely need to be taken into account, for example, when building hospitals or when rebuilding certain wards. And fourth, establishing and strengthening antimicrobial stewardship programs to ensure appropriate use of antibiotics, including prudent use of broad-spectrum antibiotics and further reduction of prolonged antibiotic use after surgical interventions. The results from this point prevalence survey and of previous point prevalence surveys coordinated by ECDC repeatedly and consistently show that a higher level of implementation of the measures that I just mentioned is associated with a lower proportion of antimicrobial resistance in bacteria responsible for healthcare-associated infections. To conclude, I would first like to thank the member states, the other European countries that participated in this point prevalence survey, and all the personnel that trained evaluators and then went to collect data, clean the data, verify the data before sending them to ECDC. And we're thankful for the participation of the member states. I would also like to emphasize that the situation regarding healthcare-associated infections, antimicrobial use, and antimicrobial resistance sometimes varies a lot between European countries. And ECDC is there to support national efforts to address this problem by providing easy-to-use tools and indicators for each country to identify gaps and set improvement targets for safer hospitals for all patients in Europe. Thank you.
Thank you very much, Dominique and Andrea. We open the floor for questions now. If you would like to take the floor, please raise your hands and remember to turn on your cameras. No hands up now for the moment. So we received a couple of questions. Okay, we have one hand up. Julien from Le Monde. Please go ahead.
Hello, good morning. Do you hear me?
We can hear you.
Yes, thanks a lot for this press briefing. I'd like to know, I understand from the reports that we shouldn't, as journalists, or maybe more, we shouldn't compare countries, or the ECDC itself didn't produce a map comparing the HAI situation between countries. I would like you to be maybe a little bit more specific on the reasons why we shouldn't make such comparisons. Thanks.
Dominique, please go ahead.
Yes, thank you for the question. You can certainly compare countries for many of the indicators. For example, antimicrobial resistance, antimicrobial use, all the indicators of infection prevention and control, and antimicrobial stewardship, and the resources in a hospital. But we put one single caution, and there are some data that need to be interpreted in caution, and this is the prevalence of healthcare-associated infection. And this is because the availability of personnel and the knowledge and the patient case mix in the hospital, and these are actually mentioned at the bottom of the graph and the country profiles that we will produce. All these actually lead to more infections being found in the countries that are very good at finding them, and less infections being found in countries that maybe do not have all the skills or the personnel to find those infections. And even after validation, there are some rates that appear too high in some countries that have been very good at finding the infections. And I'm talking, when I say rate, I'm talking about the prevalence of a healthcare-associated infection, and rates that are much too low in other countries that obviously have not been very good at finding them. So this is the only indicator for which we would advise readers of a report to approach the numbers with caution.
Thank you.
Thank you, Julien. I don't see any other hands up for the time being. We can go to a few questions that we received offline. The first one, as you are well aware, many countries do have national infection prevention and control guidelines and protocols, but they are not followed at hospital level, probably in many cases due to lack of resources. So are hospital-acquired infections simply a matter of insufficient allocated money? Dominique, can you take this one, please?
Well, the causes of healthcare-associated infections are complex. And as we mentioned, that requires a multifaceted approach. Well, while some of the measures cannot be immediately implemented, we mentioned the number of single rooms, which, if they were available, will allow for isolating patients that have been found to carry or be infected with multi-drug resistant organisms. This should be a one-time investment, but of course it's a bit difficult. Should be easily integrated, and as I just mentioned, in renovation costs or rebuilding a hospital, but it costs money, and I agree with this. Now there is evidence from OECD that infection prevention control actually pays for itself. OECD shows in a report that was released last November that €1 invested in a mixed package of interventions actually returns almost €3 in savings and in gains in productivity. I'm not sure these numbers are very well known, but we trust these numbers. Now that I mentioned funding money, I don't think it's the whole story. Of course, financial resources are important also for hiring personnel, but compliance with guidelines and protocols, changing behavior should not cost much. Changing the behaviors of workers, prescribers, visitors, patients is essential, but should not cost much. Simple actions like hand hygiene can have a big impact. And we again in the report by showing that the higher percentage of beds that have alcohol hand rub at bedside, the lower the prevalence of antimicrobial resistance in the pathogens that are responsible for healthcare-associated infections. So this actually should improve the use of alcohol hand rub, but it's also a reminder. Seeing the bottle at the bedside is a reminder to improve compliance. And these should not be very costly and do not need an enormous planning. So yes, funding is important, money is important, but it's not the whole story.
Thank you, Dominique. Now we have a question for Andrea. Such a high number of healthcare-associated infections does not only have a direct implication for patients, but may also impact the trust of population in health institutions. This may translate, for example, in people delaying their consultation with a doctor or postponing surgical interventions. What advice would you give to the public health sector to avoid a trust crisis?
Close your microphone. Thanks. So as we have mentioned, there are it's not one single measure that we can and have to use. It's a whole bundle, and among those that there are measures that are actually very visible. Dominique just mentioned the bottle of alcohol at the bedside. It's not only a reminder for the hospital staff, it's also something very visible that patients and visitors see when a nurse comes or a doctor comes and disinfects their hands before they come to a patient. It's very effective in mitigating healthcare-associated infections, and it is a very simple measure that it can be visibly conveying the efforts of a hospital to combat these healthcare-associated infections. Of course, there are also measures that are much less visible, and here I think communication and transparency are very important. Communication of the general approach a hospital has to all the measures they are taking to prevent and find early such infections, and in case that despite all efforts, there is an outbreak, then I think transparent communication is even more important, so that a hospital can show what they're doing to control the current situation, but also what they're doing to prevent future occurrence or minimize at least future occurrence. So there are a number of things, easily visible measures, and then good communication and transparency, where hospitals can instill trust that they are serious about controlling and preventing such infections.
Thank you very much, Andrea. Do we have any further questions? I don't see any hands up at the moment or anything in the chat. Okay, so we can close the press conference for today. Thank you very much for attending. Thank you very much for your interest in ECDC and on our latest data on healthcare-associated infections and antimicrobial use in European hospitals. If you have any questions, any comments, or need additional information, please do not hesitate to reach out to us at press@ecdc.europa.eu. Thank you very much, and until next time.